So thank you all for coming out this morning and spending your Saturday with us here to learn about melanoma. The medical management of melanoma has come a long way, and it's a really exciting story to tell, but it's hard to cram into 30 minutes. So I'll do my best to talk fast, and I'm hopeful you guys stay with me here. So as Joanne Jeter shared with you earlier, melanoma has an incidence of around 18 per 100,000, but this has been increasing pretty steadily over the last several decades. The stage at diagnosis, fortunately, most of this is detected early and is surgically resectable, but it's these advanced stage patients, those that have positive lymph nodes, such as what Dr. Taranto might detect during her surgery, are the ones that we're going to concentrate on here. And then, of course, those that have spread cancer or stage 4 are the ones who really need desperately to get effective therapies. This slide I prepared when I got my first job. It took me a while to get there. I was almost 40 years old. But in 2009, I started my work at the Huntsman Cancer Institute. And at that time, I was telling patients and their families to expect almost a 90% death rate at 2 to 5 years of stage 4 melanoma. Now, this number has gone up quite dramatically. We don't yet know how far. When we look at 10-year survival endpoints, we need to know how effective our current drugs are there. But suffice it to say, things are so much better now than when I started my practice, and it's been terrific to be a part of that. So we're going to talk about stages 3 and 4, and first we're going to concentrate on stage 3 because that's where I've put most of my academic work over the last several years. So when a surgeon cuts out melanoma, particularly those patients that have an involved lymph node, unfortunately for many of the patients, there still is cancer left behind. Now, it's not because they haven't done a good surgery. It's because our scans and technology can often detect only down to about 6 millimeters worth of tumor. So that's like a pencil eraser. So we estimate for those patients that ultimately go on to relapse, they may have as much as 1 million cancer cells left in their body after surgery. So we obviously need to try and get rid of those cells, subsequently adjuvant therapy. Where that disease is distributed is also important. So there were some nice pictures shared previously of what it looks like when this cancer comes back regionally. You probably remember that patient with the tumors growing up underneath their arm. That's maybe about half the time, and then the other half of the patients who relapse do so at distant sites. So these would be areas of bone, lymph nodes, lung, liver, and most concerning brain and bone. So those are areas when the cancer comes back, it can cause very bad symptoms. The good news is that when we're doing good surveillance, most of our detections are actually silent. If we do a scan of a patient after a surgery and find a tumor, oftentimes we can start treating that person before they ever would become symptomatic from the cancer. But wouldn't it be great to prevent all of this? And that's the goal of adjuvant therapy. So many trials have completed. This is a long list, and probably the largest I'm going to show here. Interferon has been around a long time. It has a close cousin called pegylated interferon. This is a drug that allows higher levels of the active component to remain in the blood after a dose. Biochemotherapy has been explored and still used in very unique adjuvant scenarios. And then finally, multiple vaccine trials and a current Ipilimumab versus placebo trial has resulted in a new FDA approval of Ipilimumab in advanced melanoma. There are a lot more on the pending list here, and the world will change again probably within the next 2 to 3 years as these trials report out. The one that probably is closest to that reporting are these two with targeted therapy, and you'll be hearing about those, I think, within about a year and a half. So interferon. Interferon is a drug that's been around a long time, and it was actually first described in 1957. It's got its name because it interferes with viral replication, so hence the name interferon. As it turns out, the way our bodies recognize cancer and recognize viruses are actually quite similar. And it was through the use of this drug that we learned that it could stimulate natural killer cells. These are kind of like the Marines of your immune system. They go out there and take out cancer. They're directly anti-proliferative, meaning it can hit that cancer cell and stop it from growing. It is anti-angiogenic, so it can starve the cancer cell of its blood supply. And then finally, it can upregulate HLA antigen presentation. So these are like the flags on the surface of those cancer cells telling your body that it's abnormal and it has to be eradicated. So it is a relatively weakly active drug in stage 4. And by weakly active, I mean it only can shrink tumor in about 16% of the patients that receive it. We don't really use it much anymore for stage 4 cancer. This is old data that I'm sharing with you. But at the time of its development, it was the best thing that we had, and that's how it made its way into stage 3. This is a table of 1993 data on interferon showing that 16% response rate. And for those of you that have read a lot about melanoma, you'll realize how far we've come. This is at the time, the best data that we had in melanoma, and it's reflecting only 380 evaluable patients. Our trials now are in the thousands. Our data is tons better. And this was the kind of result that they got. So when they treated patients with interferon, that's this curve here, and compared them with those who were treated only with observation, the drug delayed the cancer's reoccurrence consistently by about 1 year. And that was a really important advance. This trial, 1684, began in 1984. So it gives you an idea of how far back we're going when we're talking about the first ever immune therapy trial to show an overall survival advantage in melanoma. So it's been around a long time. It got its FDA approval in 1995, and it really has been the standard of care in the United States and the control arm for most of our cooperative group studies for decades. It's now entering its 20th year. I'm showing you here data that's compiled of all of those trials. So we've got now 20 years worth of experience with interferon. We've compiled 10,000 or more patients worth of data in several meta-analyses. And those meta-analyses, when you pool those data, consistently show a 1-year delay relapse and a modest overall survival benefit for patients with interferon. Now, the downside to the drug is that it does have some toxicity. And another question that we have to ask is, with all of these advances that I'm showing here between the year 2010 and 2015, do those differences that we saw in those early trials still mean something today in our patients with stage 3 cancer? And unfortunately, we don't know the answer to that, but we have some newer trial data to talk about in stage 3. The most important of which is this trial. This compared a placebo to Ipilimumab at 10 milligrams per kilogram, and it was a study designed in Europe. And in Europe, they didn't embrace interferon the same way the US did. But many of us, including me, participated. We had lots of patients contribute to this trial. And it studied 950 patients, with its primary endpoint being its delay in relapse. It was never really powered to show an improvement in survival. And it did just that. It proved that this new class of medications, which works fundamentally differently from interferon. This is now, instead of pushing the gas pedal down with our immune systems like the interferon, this is a drug that takes the brakes off. And this proved that that type of approach, that type of medication could work in stage 3 cancer. And the effect was approximately a 1-year delay in relapse. The downside to this drug as well is its toxicity. And I'm going to kind of cone down on a few points here. Let's see if I can get all the red bars up. First of all, to understand toxicity, we put these in scheme of grade. So a grade 1 toxicity would be something like, maybe a little bit of a rash that is a bother, but something that you can live with. A grade 3 toxicity is something much worse. It's something that might make you feel sick enough to go see a doctor. Perhaps even require a hospital bed. And by the time you're at grade 4, that's considered life-threatening. So some of the toxicity that this drug is creating is quite serious. The commonest is gastrointestinal. This drug can cause a lot of diarrhea. That ranges from kind of bad, maybe 4 stools a day above what you normally do, to super bad, like 10 stools a day, barely able to keep up with fluids. And it's those kinds of events that unfortunately led to the worst possible complication of all, which is death from treatment. 5 patients on the trial died as a result of drug-related adverse events, 3 of those with colitis, 1 with a heart condition called myocarditis, and another with nerve problems called Guillain-Barré. But when you think about the risk of death from melanoma, this number is not as bad as you might expect, but it's very concerning. And when you're talking to patients about which of these drugs to pick, interferon or ipilimumab, you really have to take these risks into account. The good news is that even the worst possible toxicity that we can create with the drug often is reversible with steroids. And we'll, for example, see very bad diarrhea, but 93% of the time, if we give a course of steroids over about a month, we can completely shut that off. There is a small percentage, however, that will have prolonged complications and perhaps life-changing morbidity as a result of the treatment. Also a concern when you think about the fact that we're going to cure more than half of the patients with their melanoma. And if they have to live with something, potentially a nerve problem or a hormone problem for the rest of their life, that's of a worry. So both drugs, interferon and ipilimumab, have their pluses and minuses. They delay cancer from coming back a year. Both are sometimes difficult to tolerate. And in the stage 4 setting, we've been learning about newer drugs that are safer and they cause better responses. So we're hopeful that we can advance them into the adjuvant setting. This is a trial with pembrolizumab, and I'm going to try and explain this slide in detail. It's called a swimmer plot. So each bar that you see here is a patient who has enjoyed a response from their drug. And these are patients that have measurable tumor now. We're not talking about the surgically resected. We're talking about people that have tumors that we can see on a scan in their lung, for example. Well, when those tumors start to shrink, and they shrink by a certain percentage, we call that a partial response, and that scores as a yellow triangle here. So you can see a lot of these patients are getting a very nice reduction in tumor early on in their treatment. The red triangles are what are most important when we're thinking about using this drug to cure a patient after surgery, because those are patients who have a complete response to their cancer. So if you can imagine a drug that's able to take a very measurable large tumor and make it go to zero, the patients that we're treating who have undetectable tumors, but again, this is the pencil eraser sized tumor that we can't see we're trying to treat, we probably have to treat them for 52 weeks or at least a year before we would expect to eradicate every last little bit of cancer in that patient. So that's what's led us to design the trial that I'm going to talk about here in a minute. This is a much safer drug as well. You may remember back to that previous slide that the overall grade 3 and 4 event rate with ipilimumab was pretty close to 30%. This one is at least half that, a much bigger improvement in terms of drug safety. So this trial sets to compare pembrolizumab, which is that PD-1 inhibitor, versus standard of care. And presently, the standard of care arm is interferon, but we're about to introduce an amendment to allow the newly FDA-approved drug ipilimumab as a choice for our patients. We take patients of multiple stages, but we're taking mostly the higher risk resected patients. And at the bottom of this, these are patients that have positive lymph nodes or lymph nodes that they can feel. And we'll take patients clear up to those that have had resected cancer for stage 4. So for example, sometimes we'll see a single lung tumor, and we take that out by surgery expecting to cure the patient. Their risk of relapse is still high, and therefore they'd be an excellent candidate for this study. It is a 1,200 patient trial, so there's lots of folks that are participating, and Ohio State is getting geared up to enroll here. We're hopeful that we can accomplish this over the course of about 1 year's time in terms of accrual, and it will take a few years to have the data mature. The drug's comparator pembrolizumab for a full year. This is given by IV every 3 weeks. And we're going to randomize to an FDA-approved standard, either high-dose interferon or ipilimumab dosed at 10 milligrams per kilogram. The earliest this could report out is the winter of 2018. That's study year 3. And the reason it takes so long for this to mature is that we have to score enough events or relapses, unfortunately, for the data to mean something, for us to really see a difference between the two treatments. So really the patients that are in this setting that have had their cancer resected do have some big decisions to make with their doc. I have a bias, a personal opinion, that this is probably one of the best things that they could pick. But of FDA-approved options, they have Ipilimumab and Interferon as FDA-approved standards. Biochemotherapy is still a choice, as is pegylated interferon. And getting to this decision is not so easy. So I thought I'd pause for a moment and tell you some ski stories. I live in ski country, and unfortunately now recovering from a knee injury thanks to my hobby. But anyone recognize these two guys? Yeah, this is Phil and Steve Mayer, and they won gold medal in the 1984 Olympic Games in Sarajevo. And I put this up because 1984 was the year that interferon actually was started in its clinical research. The other reason I put this up here is I think that their skiing style is a lot like interferon. It's measured, it's careful, and although you can have some challenges in a slalom event, it is actually a very safe treatment. These guys often get to the bottom of the hill standing up. Ipilimumab can look a little more like this. and can anyone recognize this skier? This is Hermann Maier. Growing up, he was a boyhood hero. We called him the Hermanator. And he was a terrific downhill ski racer from Austria. And this happened in the 1998 Winter Olympics in Nagano, which actually, as it turns out, is the same year that we learned about the key target for Ipilimumab. So we're going to transition here and start talking a little bit about our advances in stage 4. And this is now kind of paving the way of where we're going to go with stage 3. And the decisions are difficult. They really hinge on these mutations. Dr. Jeter earlier mentioned to you that there are mutations in BRAF found in the cancers of a lot of our patients. And we divide the algorithm into those that harbor the mutation and those that don't. And I'm going to walk down this path first because it's a little more simple, because those that don't have a BRAF mutation really should get immune therapy. But the hard decision is actually what kind of immune therapy should they get. And now they have a lot of different options. To figure that out, I'm going to show you this trial. And for those of you unfamiliar, this is called a waterfall plot. A waterfall plot is highlighting exactly what it looks like when a tumor responds. So these tiny bars, and they kind of all blend together. I'm sure this doesn't look like bars at all from the back of the room. But each line here is a percentage reduction in the patient's tumor. This is one of the newer FDA-approved drugs, nivolumab, or PD-1 inhibitor, and you can see that most patients that receive this drug will enjoy a response. Well, when we put nivolumab together with ipilimumab, which is the drug I was just telling you about, we captured more patients. We had more responses. And in fact, we improved that probably by 15 percentage points. So this does indeed look quite a bit more active than ipilimumab by itself or nivolumab by itself. The unfortunate thing is this is not entirely straightforward. So if you look again at what happens to these patients as they go forward in time, those that get the combination drug do appear to do better in terms of their relapse status. Those that get the single drug do slightly worse. But the toxicity is so vastly different. When we combine these two drugs, we take the toxicity way up there. It happens faster. It happens more seriously. And I've had a lot of patients hospitalized as a result of diarrhea and other complications related to the two drugs. And so we don't yet know which of these is better. And until I think we see overall survival, meaning are the patients that are taking the risk with the extra toxicity really live longer, my personal practice is to give most patients the single drug by itself. It's safer. It works extremely well. And I can guarantee to that patient that they're not going to miss work days and they're not going to land in the hospital most of the time. But for those who have really fast-growing tumors, and these are folks that have tumors sometimes as large as a grapefruit growing in their liver, they need a response right away, and it's worth taking the risk with the extra combination of drugs. So now for the BRAF mutated population. These folks do have more choices. And the real choice is which to start with. Should we give them immune therapy first, or should we give them targeted therapy first? Well, there are 1-hour lectures on each one of these branch points in this slide. So I'm going to distill a lot of data into a few short concepts. What a lot of docs have done is they've opted to take the patient that has very high tumor burden and give them targeted therapy. It works faster. It's pills. It's very easy to give. And then take those with a smaller volume and give them immune therapy. I don't necessarily agree with this. And you certainly can rescue patients after you've been treated with BRAF inhibitor with immune therapy, and similarly on immune therapy, rescuing them with targeted therapy. But when you look at the longer-term results, the patients treated with targeted therapy can have excellent survivals. And this gets to the first slide I showed you. Remember, I told you it's about a 90% death rate at about 2 years' time, which is out here. This is a population of patients that were treated with targeted therapy, and we have at least tripled that number with just this one trial, which is incredible. So, and then this is the combined nivolumab and ipilimumab trial showing just progression-free survival, but I expect the OS curves to be sitting up somewhere in here. So which is first? We honestly don't know. And to answer that question, we've designed a clinical study, which is going to take patients and randomize them either to the combination immune therapy or the combination targeted therapy. And then at the point their disease progresses, switch to another arm. And hopefully this will answer our question over the next 3 years of which is better in BRAF-mutated melanoma. So the future does look very bright. And this is kind of a sword that cuts two ways. On the one hand, we have got a terrific number of drugs to work with and targets. Unbelievable in comparison to what we started with just a few years ago. But to actually have the number of patients and the number of trials and the funding to do all of the combinations that we need to with the BRAF inhibitors and the immune therapies is really quite a daunting task, but we're doing it. And we have a lot of studies, many of them open here at Ohio State, which are going to move this far forward over the next several years. So with that, I'd like to thank organizers, and in particular, I want to thank Val Guild for such a terrific event. I've now done 3 of these with her. I always have such a terrific time here. And I'd like to thank those from Ohio State, Carrie Kendra and Joanne Jeter, for being such great hosts to me while I'm staying here in Columbus.